So my name is Lorraine Dickey. I am a physician in the United States. I'm a senior neonatologist working with sick and small babies and their parents and families. I'm also a board-certified hospice and palliative medicine physician, and I developed a project in about 2006 that I'm now currently doing full-time called the Narrative Initiative. So I'm the founder and CEO of the Narrative Initiative. With the Narrative Initiative, we help people use their personal story to learn about language, word choice, communication, close listening, and we have found that through research over the past 10, 12 years that this improves their resilience, both personal and professional. It helps combat compassion fatigue, helps decrease burnout. It increases the ability of teams to work together. It increases the ability of them, the participant, to actually deliver better patient and family-centered care. And it brings many of them back to the reasons why they got into the business to begin with. It kind of re-energizes them. Having been an advocate for patient and family-centered care, probably the biggest developments have been the voice of the patient. In America, the valuation system of healthcare has changed to where the patient voice is now part of that evaluation system. And that's one way to get the system to change is to say that that voice and the survey results directly from patients change to some degree how you're going to be reimbursed. And I think that's probably one of the bigger changes. I still think there's a lot of room for improvement. And it boils down to improvement of the actual experience of care, the delivery of care, and what does that look like for me as a patient and for you as a provider? Because oftentimes we say the same things, but we mean very different things from that standpoint. So I think there's a lot of room for improvement. I think a lot of the things that I've heard, at least this morning, from people who talked about the barriers to kindness, which is we're very busy. We in America, as I'm sure you are, have a very electronically run medical system now. So very much of what I need as a provider or somebody in the healthcare profession is I need the information that you have that goes into my template. Anything else you're telling me can be extraneous, even though that may be the most important part of what you're actually trying to tell me, why you're here. So I think part of that barrier is, that barrier to kindness, so to speak, is a refocusing a bit on what kindness means. What does that word actually mean to me, to you, and how do I still fill out this template, giving you the perception that I'm being kind in a way that you perceive it as being kind? So I don't think it takes that much more time to be kind. I think when people say, I don't have enough time, I think it's, I think kindness is really a phenomenology topic. When you talk, it's really the science of experience. To be kind, it takes two people. It really does. So you can be kind to yourself, but if to the kindness we're talking about, there's a giver and a receiver. But it's a two-way interaction. And I think too often, I don't have time to be kind means if I'm kind, what am I going to get in return for it? And I think if you refocus that, just reframe it a bit, everything that you do that's kind, you probably do get something in return. It's just a recognition of what that could be. And perhaps we need to be more aware of what that is we are receiving. So it's not just a straight output, but there's actually a two-way street going on here. And you actually do receive, whether it's a thank you, a kindness, a hand gesture, you do receive something in return for being kind. When you're talking about the gathering of kindness, from my perspective, where I talk a lot about communication and language, after you get down through a series of barriers ultimately, the connection between two people is just a human connection. If you can get down to that human connection, that's where kindness lies. That's where kindness is inherent. It is there. Small children without all these barriers talk about kindness and what kindness means. And we've just over time built up many barriers. So if you can get down to this fundamental empathic compassion level, which again is a two-way street, and you have that relationship outside of the power relationships that exist, that is where kindness exists. And it's always there. But I think we cover that up with a number of different barriers. So I think it's perhaps less about trying to tell people to be kind, or here's how you be kind, rather than you are already kind, and that exists at the human to human level. And that's at the empathic level. How do we just merely scrape off some of these barriers so we don't have to spend so much time, and we can get at this kindness level, this very foundational level of relationship sooner? That's where it's helpful for both people, in that, where people both walk away understanding that it was a kind communication, a kind experience, not just exchange of language, so to speak, but meaning from that standpoint. So I would tell the leaders, I think it has to do less with telling people they need to be kind and more with understanding what the word kind means to people. Sort of like patient-centered care. Care exists in the concept of the person being cared for. So if you want to know what's kind, how can I be kind to you? What does kindness look like to me? So the same thing is with care. So I think we have to ask a little bit, what does kindness look like to you? And what does kindness look like as a provider in the healthcare system? From that, kindness to me may be, your visit is 15 minutes. Thank you for not giving me an extra problem today. That may be kind, but that's not necessarily perceived as kind on the other end of the patient experience. So I think that's very important. So I think we have to get down to what that definition is. And then it is very much about the person-to-person interchange from that standpoint. And how do you simulate experiences that help teach compassion, that help teach empathy, that help teach the perception of kindness? Telling something to be kind is a lot like telling a 3-year-old to be good. Yeah, they're good. But you have to kind of tell them how to do that. And I think from the healthcare standpoint, it's really more about how to get rid of some of the barriers that we put in there all the time. Like somebody today said, I can't afford to be kind. Well, that's a very interesting choice of language for a provider to say, I can't afford to be kind. What does the word afford mean? Is it a monetary thing? Like if I pay it, I'm not going to get anything for my money? Why afford? Is it because maybe that gets at a human part, a human level, where I can't let down my professional level and keep going throughout the day? I have to have this suit of armor to get through my day. And if I can't afford to lose my suit of armor, to have compassion and kindness sneak in here, because then it's too hard to put the suit of armor on again. So perhaps we need to just look at that language and figure out why why that word, and why is that the barrier. Perhaps one of the best things to do is to simply listen. And it's a type of listening that requires listening without judgment, listening without bias and what you think is going to come at you. It's an open type of listening. And then again, I think it's listening for what somebody is actually trying to tell you. And that requires paying attention to words that are actually used, as well as what they're trying to communicate through other ways other than language. I think that's one of the best things that leaders could do, is to simply have a quiet time to learn to listen well, and then to have some time to reflect on how to put that into action or how to disseminate that within their organization. People only change if it's in their own best interest. It really is. When I've done a number of workshops with audiences who work in any given hospital, one of the questions I ask is how many people in this audience have to have their health care here? Because you are insured by the hospital, which means your choice of healthcare systems is limited to the system that you work in. So half the audience, 2/3 of the audience raises their hands. And I said, well, if you have to come here tonight with your son, or you have to come here with your mother, or heaven forbid, you should be a patient yourself, would you not want to be in a kind system? Would you not want someone to ask you, how is it best to care for you? What would be, if I did this, would this seem kind to you? And everybody says, yeah, I would. And I said, well, then how do we make that system work? I'm not talking about changing the world, but I'm saying if that's important to you, then go out and do that for your patients, because one day you or a family member will be a patient in this hospital. So it's up to us to change that culture because it's in our own best interest. Now that seems very short-sighted, but you can't just appeal to everyone's altruism because people get burned out by that. You really have to say what's in it for me, okay? So if I'm going to have to go out and adjust my style of caregiving so that it's perceived as being more kind, what am I going to get out of that? Am I going to be rated differently because of it? Is our hospital going to be reimbursed because of it? Or am I going to come to work in an environment where I may need to use these services sometime? And I'm in it to make a better environment because it may help me or my mother or my father or my son from that standpoint. So I think you have to start at the individual level, to be really honest with you. And you have to give people a reason to change. And one of the reasons that we use story at the Narrative Initiative is because it gets at that personal reason to change. This is my personal story. This is what I perceive as kindness. This is an unkind act that happened to me. This is the reason I want to make a change in this culture. So the whole idea behind bringing invested people together to tell stories is to get the other perspective. So if you can bring healthcare providers of multiple types with community members who are care receivers, so you've got the care providers and the care receivers together, then you can have conversations based on personal story about what kindness means, the barriers to kindness, and how do you overcome those barriers. And the beauty of that is then you begin to see it from the other perspective. And that, I think, will change hearts and minds. It's not that reading of the feedback on a survey that you get, whether it's positive or negative, because you don't have the emotional component of hearing from somebody and having them read their story. It's that emotion that triggers somebody wanting to change. Emotion trumps logic every time. So you have to have that emotional connection. So if you bring them both together through story, you can actually leave the room with both groups understanding what the barriers of the other group are to giving and receiving kindness, as well as concepts about how to overcome those barriers that are meaningful. They're not coming from the hierarchy down or administration down. These are patient and provider driven ways to pragmatically change the system.